Hey guys, so today I'll be explaining how to understand a screen test result. And the way to do this is to understand the sensitivity values, specificity values, PPV and NPV values. And then also we need to take into account of any biases involved, and we'll even go through some practice problems for you to understand the concepts better. So now we'll be going through the screen test definitions. So as we know, or we don't, it's okay. Screening tests usually have a study behind them. So we need to know if the test is reliable and such. And so studies are done to make sure that we can interpret results of the screen test. So in this study, usually there is 4 variables, A, B, C, D. And so when a new test is made, we need to understand if it's good or not. So in this case, can this test detect people with the disease well, without the disease well, or does it always produce wrong results that misdiagnoses people that are actually healthy and says that they're actually diseased, and vice versa? So in this case, A represents people with the disease and the test correctly diagnosing them as someone with the disease. Hence, it's a true positive. But B, on the other hand, represents people without the disease, but the test diagnoses these patients with the disease. Hence, it's a false positive. C, on the other hand, is also incorrect because the test diagnoses people with the disease as a person without the disease, and hence it's a false negative. D is correct because someone without the disease should be diagnosed as someone without the disease. Hence, it's a true negative. Now, we'll go through the definitions as I mentioned before. So, firstly, there's sensitivity. By the book definition, it's defined as the true positive rate. But for your understanding and for clarity, you can think of it as out of those with the disease, how many diseased can the test pick out? And the formula displays how the worded sentence is displayed in numerical form. And the way I have to think about it is that, wow, the test is so sensitive, so it always agrees easily. And I also have another tip for specificity. So specificity, its book definition is the true negative rate. And then for our understanding, we can think of it as out of those without the disease, how many of the non-diseased people can the test pick out? And this is again displayed in the formula. And the way I could think about specificity is that, dang, the test is so specific, it doesn't always agree easily. Hence, this refers to negative rates, or you can say negative diagnoses. Now, there's also the PPV, otherwise known as a positive predictive value. It's defined as the proportion of people who test positive. And for the calculation definition, out of those who test positive, how many people are actually diseased? And again, the formula is shown on the screen. And for negative predictive value, the book definition is the proportion who test negative. But the calculation definition is defined as out of those who test negative, how many people are actually non-diseased? And this can be displayed in the formula as shown on the screen again. Now, I'm going to go over some tips and misconceptions that I had as a student, and I was never actually fully taught this, and I had to figure this out on myself. So, when we screen a patient, we must use PPV and NPV values to interpret their results. We cannot use specificity or sensitivity values. So, when we talk about PPV and NPV, how does this help us? In this example, we'll say that the PPV value is 15%. So if there's 15%, then that means if the patient tests positive, remember that PPV is defined as out of those who test positive, how many people are actually diseased. All right. So with this definition, we can modify it and say that it represents the likelihood of someone having the disease after testing positive. So even if there's a low PPV value, and this PPV value is still higher than the general population, say 1%, that means this patient's risk of having that disease is 15% compared to the 1% that he or she had before. So now she has an increased risk of having the disease. Hence, we need to do further testing to make sure that the person is actually deceased or non-deceased. Notice that I say deceased and non-deceased rather than deceased or healthy. This is because even though the test tests for someone that is deceased, the opposite doesn't necessarily have to be that they are healthy. Because even if they're non-deceased for this disease, they may be deceased for another disease. Hence, we cannot say that they are actually healthy. And so we cannot assume that they are healthy. Which is why we say non-deceased rather than healthy. Alright? So, we'll also talk about sensitivity and specificity. If they don't have value and if we don't look at them once we test for a patient, so why do they exist? Well, sensitivity and specificity also plays a role. They also show the appropriateness of the test rather than to interpret the test result. For example, a test may have a high PPV value, but it might have a low sensitivity value. So this means that not everyone who are deceased will be detected. So this is actually not very appropriate either. I will further elaborate on this concept later. Yes, because it may be confusing since actually sensitivity and PPV both use the value of the true positive value. Now, when referring to accuracy, this always refers to PPV and NPV. Okay? For this one, you don't have to overthink it that much. Literally, if the person tests positive and if it's always correct and the test always makes sure that a positive test means that the person is always positive, that means the test is pretty accurate. Furthermore, prevalence actually plays a role. So if the disease is more common, there will be a rise in PPV values, not NPV. Assuming that the test is good at picking up people that are deceased, then obviously more people will be correctly diagnosed. Notice that I said if the test is good at picking out the people who are deceased. So therefore, prevalence does not play a role, but rather how good the test is in itself. This is why sensitivity and specificity values are not affected by prevalence. Another confusion would be, why do we use PPV and NPV rather than sensitivity or specificity? Well, obviously when you test positive, you will have to look at that kind of range. If you look at the table, you will need to look at the row that gives information about positive test results. You want to know, out of those people who test positive, what's the likelihood that a positive result mean that they're actually positive? And then you would compare this to the baseline risk level of the general population. You wouldn't use specificity or sensitivity values in general. Another way to think about it is that you want to understand if the person has a disease. So that means there are only two options. Either the person has a disease or the person does not have the disease. And with sensitivity, it only talks about people who have the disease. So this wouldn't be helpful to you. The reason why prevalence only affects PPV and why how good a test is does not necessarily help is because given a very, 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 very large sample size, like as in the whole world, the test has a higher likelihood of making errors. And this is why the more rare a disease is, the higher the chances the test will make a mistake, and therefore the higher the NPV value will be. Another confusion that I had as a student was, does sensitivity and specificity values affect PPV and NPV values? So we'll talk about that now. So in this slide, you can see that there are two scenarios, one with lower prevalence and the second with higher prevalence. So in scenario 1 and in scenario 2, sensitivity and specificity are both the same. But you can see that there is a difference in PPV and NPV values. Therefore, this shows that the higher the prevalence, the higher the PPV values will be, and the lower the NPV values will be. Now, we'll move on to actually interpreting the values in a contextual manner. So, we now know that sensitivity and specificity values do not affect the values of PPV and NPV. However, individual changes in the values of the table will cause different values. This is because if there's a decrease in true positive values or true negative values on their own, it can cause changes. Remember through the formulas that the true positive value is involved in PPV and sensitivity, while the true negative is involved in NPV and specificity. So, what happens when there's a decrease in true positives? Well, if there's a decrease in true positives, then there may be more false positives in proportion to true positives. This would mean that most people who are diseased need further testing to confirm this disease, and therefore this causes low PPV. On the other hand, a decrease in true positives would mean that there will be more false negatives in proportion to true positives. So then most people who are ill in the population will be left untreated, and this means low sensitivity. On the other hand, a decrease in true negative would mean that there will be a high false negative compared to true negative ratio. Because this test is not reliable, regardless if the patient tests negative, they will need to do further testing anyways. So a high false negative and low true negative causes low NPV. Now, in the case where there is more false positives than true negatives, this will mean that most people who aren't diseased in the population will actually be treated or will need to undergo further testing. And therefore, higher false positives than true negatives cause low specificity. You have to remember that PPV and NPV are used to interpret the results of a patient, but can also be used to evaluate a test. Specificity and sensitivity mainly refers to how good a test is at picking out people who are deceased or non-deceased, not used to interpret results of a patient. Below, there are two more bullet points where I explain where low PPV is similar to low sensitivity and low NPV is quite similar to low specificity. And now we'll be talking about screening test bias. So you have to remember that most people who show up for a screening test show up because they actually don't know if they have the disease and they actually are relatively healthy. So when we're screening for patients, we are dealing with a relatively healthy group of individuals. And they appear relatively healthy because they currently have no complaints and they're actually asymptomatic to the disease. So there are two kinds of biases. The first is the lead time bias. So I have explained that it is improvement in medical technology that allows us to detect infectious agents or abnormalities earlier. And this can cause an illusion where it seems that people are living longer after detection for this abnormality. So for example, we'll call this example disease A. For disease A, with current technology, we are able to detect it by age 25, and people usually die at age 60. So therefore, people will have around 35 years to live. But with improvement in medical technology, we now can detect it at 20 years old. So instead of 25 to 60, now people live from 20 to 60. So therefore, it looks like people are living longer because on paper, instead of saying that upon detection, someone with disease A will live an extra 35 years, now we say someone with detection will live another 40 years. So without medical advancements on the treatment, just on the detection, this can cause a lead time bias. There's also a length time bias, where our immune system can eliminate infectious agents given some time, but because some infectious agents stay in its asymptomatic stage longer than others, or takes longer to clear out from our body, it can seem that the disease is more common than another. Simply because of the type of screening, the disease that stays for a longer period in people are detected more often. So this is called the length time bias. Now, we'll go through some practice problems just to make sure that you understand the concepts. So this is a basic problem. So with the given scenario, you can refer back to the table that we used before. A plus B plus C plus D, in this case, will equal to 100 babies. The total population is 100 babies. And in this test, the sensitivity and specificity are both 80%. And the true positive is 24 babies, and the true negative is 54 babies. And right now, you are trying to evaluate the PPV or NPV, and also to do that, you will need to find out the values of the false positives and false negatives. So now we'll move on to the answer. So the first table on the top is what you should have started out with, because this was the given information in the problem. Now, we were also given the information that the sensitivity and specificity rates were 80%. And by formula, we can replace values. And we know that the true positive is 24, so that goes into the sensitivity formula. And the true negative goes into the specificity formula. And by calculation, we're able to find out that the total diseased will be 30 babies, and the total not diseased is 70 babies, because we will find out the total first. Because remember that sensitivity is true positive over all of the diseased. If 24 is 80% of all of the diseased, how many people are deceased? Then that would be 30 babies. And that would be the same for specificity. If we use that logic, we can find out that 70 babies is the total population of babies that are not deceased. Now, we can move on to trying to find out the total babies who were tested negative and positive wrongly. So that would be the false negative and false positive. And we can simply do that by subtracting the total population by the true values, in this case the true positive and the true negative. And by doing that, we'll find that 6 babies are false positive and 16 babies are false negative. Now, moving on to the third step, which is color-coded in green, you can see in the table that we can now add 24 and 16, because that will be the true positive and the false positive, and that would give us the total number of babies who tested positive. We can also add 6 and 54 together, and 6 representing the false positive and 54 representing the true negative, and by combining them together we get 60, which represents the total number of babies who tested negative. Okay? And now that we have those values, we can calculate the PPV and NPV, which is highlighted in yellow. Now, for the second practice problem, we have another scenario, and this is more about interpreting data. So, in this scenario, we have a disease that is not life-threatening, congenital, meaning that it's acquired at birth, and it's also chronic, which means it's life-lasting. And if untreated, it's although inexpensive, medications are lifelong. And in this case, we are talking about a first world country where the government provides medical support. And so it is not a financial burden for the government to offer these tests to the public. And results are confirmed with an invasive test. Remember that we talked about the problems of a low PPV and low sensitivity value. Anyways, the data given says that the sensitivity is high, the specificity is quite high, the PPV is low, and the NPV is very high. So, the question asks if this test is appropriate and how does the severity of the disease affect your answer. Now we'll move on to the solution. So, the verdict is that the test is not appropriate. This is because although the test has a high sensitivity, meaning that it is good at picking out people who are actually positive, a low PPV value means that there are also a lot of false positives. I have also listed some reminders just in case if you forgot the terms. And if the test is not life-threatening, then a large amount of people who test positive will need to be confirmed by the invasive procedure. And invasive procedures carry risk, and they're actually burdensome to the patient. And therefore, this not only puts them at risk for damage that may occur during the procedure, but it may cause them discomfort and sacrifice responsibilities. For example, they may need to have a recovery period after the procedure, and therefore they'll be disabled or bedridden for a few days, and that's not very ideal. So regardless of the high specificity and NPV values, and although the cost is not a financial burden to the government, taking lifelong medications seem to be a better choice over conducting this screening process. And so for these types of questions, remember that you should address all the information given to you so that it can be seen that you have taken everything into consideration, especially in an exam. In this case, I didn't actually elaborate much on specificity and NPV values. I wouldn't say that they're irrelevant, but if you already know your argument, focus on that. And in this case, it was very evident that the test was inappropriate as soon as there was a low PPV and as soon as they mentioned that it was non-threatening. It's always best to get straight to the point instead of playing tennis and alternating back and forth between your arguments, because that can seem quite confusing. Anyways, that reaches the end of the video. I hope that it was very informative. I hope I made it clear, and I hope that you wouldn't make the same mistakes as I did as a student. I just like to apologize if the slides are a bit too messy. It's just because that I would like to make these slides available to you guys, and in general, I hate taking notes, and I wished that my lecturers would always put everything that they wanted to say on the slides, and which is why it can seem a bit messy, but I hope that this is actually very helpful for you guys instead and can be used as a learning tool. So yeah, have a good day.